Hello, good evening, ladies and gentlemen. Can you hear me clearly? If you can, say yes in the comment section. Good evening, ladies and gentlemen. Can you hear me clearly? If you can, just say yes in the comment section. Right, we see some yes. Okay, let's start. Good evening, ladies and gentlemen. I'm Xiao. I'm the pharmacist from NADARAJAN Medical Center. Thank you for watching us again. Today, we're going to talk about some very important topic about ourselves. So if you don't take care of it, so you're going to feel very pain in the end. So today, what we're going to talk about, we're going to talk about our bone orthopedics. And we're very lucky to have Dr. ESWARAN today. He's a specialist, a consultant working in NACMH, and he has been working as a specialist for 7 years. So today he's going to talk about the most frequently asked questions about orthopedics, some treatments, and obviously, ladies and gentlemen, if you have some burning questions that you would like to ask our consultant later, please stay with us. After 15 minutes of the presentation, we are going to have Q&A session. So you can leave your questions as the comment, then we are going to answer you shortly. Right. Without any further ado, I'm going to invite Dr. ESWARAN. He has a nickname. He's called Jersey Doctor. Let's welcome our Jersey Doctor, Dr. ESWARAN. Hi, Jersey Doctor.
Okay. Hi.
Hi.
Okay. Hi. Nice to meet you, Xiao, again. First off, I'm very grateful and humbled to be given this opportunity to share my knowledge and experience in the field that I'm in. Okay. And I also would like to thank our marketing team, Xiao, for continuously inspiring us to believe and participate in such an event. Okay, so I'll try to do my best to fulfill this task given to me in answering common questions in orthopedics. Okay, can I start, Michelle?
Pass the stage to you. I'm gonna disappear for a while. I'll mute myself.
Okay.
Hi, Doctor.
There's some problem here.
All right, what is it? Can you share the screen? No, great.
Okay, now, hi. I hope we can see this, right? Can we see this?
Yes, I can see. Very clear.
Okay, now, okay, I've been given this task to answer most frequently asked question in orthopedics. Okay, now it's such a wide thing. I won't be able to cover everything that question that comes to me, right? So I'm going to take a few common ones and see whether it's going to work for us. Is that okay? So we're going to go with this. Okay, first question. I'm young and active in sports, and I'm starting to have knee pain. So what could be the cause, and how do I treat this? Okay, now I do get this more common now. It's becoming more popular group of patients in my practice, simply because their current trend of a lot of people are going cycling, running, mountain hiking. Those who were not fit before this, they follow this trend and go around doing this. Oh, definitely it's important. Definitely it's important for your health now. But then again, you do also see patients coming with injuries due to this, overuse injuries or new activity injuries, especially to the knees. Okay, so how we approach this is basically you want to know what is actually happening now. When you have a pain around the knee, especially in young ones who has undergone or went for some active activity, it's always important to see what is the pain generator. Okay, this group of patients usually will just come to you showing their knee being hurtful. So it's very important to see what are the causes. So the common cause, we can divide them to two. Around the knee, causes around the knee, and causes within the knee. So proper history and physical examination can settle this to find what is the cause. Why is this important? It's because injuries around the knee, such as tendinitis, bursitis, like patella tendons or other structures around, okay, these are commonly managed conservatively. Lifestyle modification, do some exercises, physiotherapy, they should settle this down. However, when they get injury within the knee, such as meniscus injuries, cartilage injuries, or even have a fall with a ligament, major ligament such as anterior cruciate ligament or rather ACL injuries. These somehow require some form of immediate attention and eventually going into some form of surgical intervention. Okay. Now I'm going to share this. I'm not going to go around with anatomies and all that. I'm just going to show you all some animation of commonly done procedures. Okay. I try my best to show just animation, and you can stop me anytime and ask me any question regarding that. So now, first thing, injuries around the knee, such as tendinitis and all, it's very easy to be treated. Well, it can be a bit tricky, but it's treatable, okay, with physiotherapy and lifestyle modification. But injuries within the knee becomes a bit tricky, okay? I show you some examples. Okay, now, I'll play this video. It's about animation on meniscus injuries, okay? So this is knee, okay, animated. So you see within the knee, you see meniscus, okay, named lateral meniscus and medial meniscus. These meniscus are very important. They are like cushion for your knee. Okay. Okay, again. Okay, so if you can see, okay, there are meniscus, okay, two meniscus in each knee. We name them lateral meniscus and medial meniscus, okay. This meniscus has got very significant function, one of them being a cushion for the bones, to prevent bones from hitting each other, stability to the knee and all that. Now, when you have go through activities and you have a fall, or you got a twisting injuries to your knee or something, you can tear your meniscus. Okay, meniscus tear looks like this, okay. Very few injuries of meniscus can be treated conservatively, especially the tear. Most of them will go some form of surgical intervention. Not all will be repaired. It depends on the type of tear and how complex they are. Okay, we generally do this scope, rather diagnostic scope or meniscectomy or meniscus repair. Sometimes we do it as a daycare procedure, or sometimes the patient is admitted. So depending on case-to-case basis, okay. So this surgery is done as a keyhole procedure. So you got 3 holes or 2 holes commonly in your knee, and it's done through a keyhole procedure where you look into the monitor and you repair or you resect them. So now this video shows how meniscus is being resected. Okay, so just go in, you see the meniscus, you assess how bad the tear is, whether it's chronic tear or it has been some time, complex where you can't repair them, or a simple tear in which you repair. So the aim is always to repair the meniscus. Okay, in event that you can't, then we do this. The reason being is if you leave it this way, what happens? So your knee get locked, okay? You have persistent pain and swelling around your knee, okay? And the tear can go bigger and bigger, okay? So that's a meniscus repair, okay? Or rather meniscectomy. Okay, then the wound will be stitched and we allow the patient to ambulate the very next day, okay? Now, there's another one. Okay, sometimes these patients who come with knee pain can also come with chondral injury, chondral or rather cartilage injuries. So these injuries can be quite dangerous if you don't take care of it. So now, can you see there's a cartilage piece? This is a knee. There's a piece of cartilage that was floating around just now, and you can see the bare area of bone being visualized. So now this you've got to do something, because if you leave it that way, they can propagate, they can get bigger. So what we do generally, this is what we do a microfracture, and this is actually the video taken patient undergoing some form of cartilage regeneration procedure. Okay, so you can see the cartilage coming back. It's not as beautiful as it is, but the point of this video is to show you cartilage injuries and how they float within the knee, especially like this. Okay, can you see this piece? So this is a very dangerous piece to leave it there. They become a loose body within the knee. Okay, so I prepared another video that commonly cause of a pain for the young ones. So now sometimes patient come to you saying that, doctor, you know what, I was playing football, I playing futsal, and I injured my knee. I couldn't continue with my game, and my knee swelled up right away. Okay, it's very painful, and I just couldn't take it. So most of the time they also come and tell you that, you know, I had a turning injury to my knee. I heard a pop sound, although it's commonly heard, not necessarily have to hear. I heard a pop sound and I just couldn't do anything after that. So this, when you examine, you tend to see a lot of them coming with anterior cruciate ligament injury, especially those who I'm seeing, those who play futsal. So a lot of us get this, including me. I've undergone this surgery as well because of futsal. This is how it is done. Animated, okay? So that is the ACL ligament being shown there. There is ACL ligament being torn because of movement. So they always get this valgus rotational movement. Okay. So now the problem with the ACL is, if you don't repair them, what actually happens? Now, if you don't repair them, what happens is your knee is unstable. So it cannot be participating in a lot of your activities, including daily activity of living. So you can say that, doctor, you know what? I was playing football. So now that, you know, I was just playing that for that evening, like a weekend warrior thing. So now I've injured my ACL. So I'm not going to play anymore. Can I treat this conservative? Well, in my hands, my advice, I tend to tell them, well, even if you're not playing your sports anymore, you have to look at your daily activity, whether your activity is being disturbed or not. Can you go and walk on uneven ground? Can you turn acutely? Is your knee stable? If you feel like your knee is moving up and about, you feel like, oh no, my knee is moving and coming back in again. So that tells you that your knee is not stable and you need to get this done. Okay, they don't heal by themselves, even if you leave them alone by, you know, for whatever years you want. And then whenever this knee moves abnormally, what happens is they go and injure the cartilage. Okay, they go and tear the meniscus, and then you tend to get a lot of degenerative process in your knee. So a lot of these patients post football, you know, when they go about 40 years old, they start putting on weight because they stop playing football, and they come with really, really bad OA of the knee, rather osteoarthritis of the knee. So my suggestion, if you've got an ACL injury diagnosed by the doctor or evidenced by MRI and all that, I would suggest you to go for, well, probably you're more prone to for surgical intervention. Of course, it's case-to-case basis, but probably the idea, or rather the advice, will be towards surgery. Okay. Now, another question. Now, this is way more common question, really. This, you see this every day, kind of. I'm aging and still keen to be active. Okay. However, I'm a bit worried of recurrent pain and stiffness with abnormal sound in my knee. What could be the cause and how do I treat this? Okay, now this is very common. We see this day in, day out. So patients are a bit aging. They're keen to continue with their very active lifestyle. Okay, you'll be surprised with the activity that people nowadays are doing. Okay, despite their age. Okay, but the thing that bothers them is their pain. So the knee pain. So there are many causes for this, including so many gout, so many. But the common is osteoarthritis of the knee. Okay, or rather we call them degenerative knee disease. Okay, in which they come with stiffness, early morning stiffness, sound, cracking sounds, or crepitus we call them. Some of them towards the later end, they even find that their knee is bending. Okay, not even in the straight line. Okay, now this kind of group of patients, what we do is that, okay, the treatment very much depends on what grade, how do we assess them. So a lot of them, they come with knee pain, degenerative form. One of the main thing that we do is we get a plain x-ray of their knee standing. So we don't to assess them properly, we tend to get the x-ray with them standing, because that's what we want to see. We want them to be weight bearing and seeing how bad is the joint space differences. Okay, and also we get history from them to see what is their expectation from the treatment. So some of them has got quite, expectation that you can't meet. Some of them say, you know what, doctor, after this, I want you to do something, and after that I want to get back to my maximum amount of activity. I want to get back this, I want to do that. So these are some of the patients' excessive expectation that you may need to address, because if you think you want to do something because you want to elevate their pain or something, and you don't meet the expectation as what they say, probably the treatment that you're giving them is a form of failure. Now, in terms of osteoarthritis, okay, the mainstay of the treatment, one of the components is always a lifestyle modification. Okay, if they are on the bigger side, their weight is on the heavier side, that's one of the first thing we tell them to do: lose your weight. Okay, you losing 1 kg of your body weight, you almost take away 4 kg of the pressure from your knee. Okay, that's significant, even 1 kg. So we tend to tell them first, okay, lifestyle. Second, we make them to be still active in their activities, but the activity has to be a bit modified. You have to be on, you shouldn't be going running, jogging for 5 kilometers, 10 kilometers, expect your knee not to give you a problem. Okay, it has to be what we call as a low impact activity: cycling, probably walking in a swimming pool, swimming, best thing. But our culture probably is not very widen for everybody to go swimming, right? So probably change of your activity and all that, and of course addressing the pain. Painkillers, one option, not a long-term option, definitely one option. So another option, a lot of patients looking at the grade, a lot of patients go for hyaluronic acid injection. Some of them take glucosamine supplements for them to take the pain away. Well, in my practice, I don't really give much of glucosamine sulfate, because the evidence is a bit low on that to see whether they can treat the pain or they can, improve their function. As for HA injection, hyaluronic acid injection, it's proven, so it does give a good outcome to patients, provided we grade them. So up to grade 3, probably it's a good thing. You can try them on, but grade 4, probably the likelihood of you getting HA injection and is doing wonders for you is quite low. So the moment patient goes to grade 3, grade 4, there are a few options that we give. So a lot of patients comes to you, they say, doctor, you know what, whatever it is, I don't want to undergo surgery. I don't want to get my knee replaced. So, okay, is there any other option? Well, used to be no option at all, but sometime now, a few years back, now a few options are coming up. So these are one of those things that I want to share with you. Okay, this, if you see this video, right, this animation, so this is a minimally invasive procedure that we do. So what we are doing is, your knee is degenerated. Okay, it's painful to walk and all, but there are 3 or rather 4 main nerves that surround the knee by the name of genicular nerves. Okay, these nerves continuously send signal of your painful knee to your brain. So what we can do is that we can block this. Okay, we can block this nerve from sending signals to your brain. So what happens is, you're not treating the problem. Okay, you are just making your brain not to get that it's painful. Okay, these are for those patients who are grade 4. Doctor, you know what, no matter what you do, I don't want to replace my knee. Is there any other option? This is an option, but this is not a permanent option, unfortunately. Okay, you have this for 1 year, maximum 2 years, and then the pain comes back. So can this be repeated multiple times? Well, in my experience, probably the first time doing is the best time. Okay, subsequent, probably the outcome might not be as good as the first time you do it. Well, this is called, I think a few companies are doing this, nerve block around the knee. Okay, this is done as a daycare procedure. It's done under sedation. So patient gets this done, it's a form of injection, and they go back the next day or the same day, depending on how they tolerate the pain. Okay. That's another one, interesting one that we do it quite a bit here. It's called subchondroplasty. Subchondroplasty is something where we think that in a patient with a degenerated knee, we also notice that on MRIs of these patients, we see a lot of bone cysts, or rather bone bruises under their knee, such as like this. Can you see this? So this is some form of a bone bruise, okay, under the knee. So this can be a very strong pain generator for this group of patients. So what we tend to do is when we do the scope, we do the knee scope, and with the MRI result of the location of all these bruises, we can actually bring in a procedure by the name of subchondroplasty. We go directly targeted to the areas of this bone. We inject calcium phosphate cements in which later on turns into bone. So this I notice in a lot of patients, the osteoarthritic pain, they improve very much with this procedure. So, but unfortunately, this procedure is not a daycare thing. Okay, you can't do a daycare procedure for this because a post-op, a lot of patients complain of quite a bit of pain. So we tend to get them admitted and observe them overnight. In which the very next day, depending on the size of the bone cyst, we allow them for full weight bearing. Okay, this is a new thing. I mean, probably it's not so new, probably a few years now, but it is very much giving us a lot of good outcome. Now, of course, now we have exhausted all this. Okay, doctor, you know what? My knee is really bad. Okay, I cannot do anything. So is there any other option for me to, get back to my activity? I'm fairly young. I'm 60. So I want to do so many things. I want to go exercise. I want to go, for holidays and all that. So I keep on slowing down my family members. What can I do? So of course, you can do a total knee replacement now. Okay, this has to be quite okay. I let the video run. Okay, just see how it is done. So this is how a total knee replacement done. So it's not like cutting a bone, a significant amount of bone or whatever. Well, the success of this operation very much depends on the patient. Okay, expectation of the patient. Okay, the main aim, the single one aim of doing this total knee replacement is to take the pain away. So you cannot do magic with this thing. Okay, so in my practice, I tend to leave until I got no more options before I do this. I don't give this as my first option. Okay, patient comes to me, a bit of a bent knee. Well, the knee is a bit, bangkok, but he's having a good activity. He's not having so much of pain. Every week he's doing his activity, not on dependent on painkillers and all that. I wouldn't suggest a total knee replacement for them. So total knee replacement should be suggested only on those who have got no more options, and it should match their expectation. Okay, the procedure is cutting a thin slice of bone on the surface where it's all has got all these jigs on it, and to get an appropriate size of the bone. Okay, and then fixing it back. So the aim is, the idea behind this is the pain of osteoarthritis, or rather grade 4 severe osteoarthritis, is because of the surface being so what they call eroded and all. So we're just changing the surface. Okay, the first aim of this is to take the pain away. Second aim, it can also straighten the alignment. So if the patient's knee is malaligned, it can also help with that. Okay, but then again, the main aim is always to take the pain away. So some patients will tell you, doctor, you know what, after my total knee replacement, what's my recovery period? What do I? So in general, the date, let's say I do a total knee replacement today. So tomorrow, or rather tomorrow, the patient will be resting. Day after, we'll allow them to walk. Okay, the patient goes back home walking. Okay, that's the general recovery of a total knee replacement. Okay, get back to activity according to what activity you're talking about. Some of them say, doctor, can I play golf again? Can I, go on line dancing again? Well, case to case basis, patient to patient basis. So sometimes some of the knee replacement can be a bit complex depending on the ligament and all that. So definitely it can, but it's case to case basis. So probably you need to talk to your respective doctors and get all this expectation right before you decide to do this case, or rather do this procedure, because matching your expectation is the definition of success of this surgery. Okay, you see a lot of patients coming and saying, you know what, doctor, after I'm doing the knee replacement, I still cannot do this, I still cannot do that. That means you're not matching the expectation of the patient. Okay, so next question. This for, what is the next question? Okay, now I'm young. I had an old injury to my shoulder, and it has been unstable since then. What could be the cause and how to treat this? Well, it's not very common, but we do see this on and off. Young patient with shoulder injury is always or almost always because of some form of trauma or rather injury. So a lot of them, I'm sure a lot of us are quite familiar with this shoulder dislocation. Okay, shoulder dislocation can be multiple direction, front, behind, downwards, and all that. But the most common being your shoulder being moved in front, so translated front. So what happens is when shoulder is a mechanism in which it is very much kept in place by a lot of soft tissue rather than like a hip bone or something. Their stability, the shoulder stability is by the soft tissues or rather the muscles around it. Okay, and also structure by the name of labrum. Okay, that keeps the shoulder center. So when you have dislocation, what happens is you tear this labrum out. Okay, I show you this video. What is a common thing? Okay. So I have to mute it because some of them what they call talk about their companies, brands and all that. So I'm not here to promote any companies. I'm just here to discuss on the common procedures that we actually do. So this is what you see. This is a labrum, we call that. Okay, this is what is torn when your shoulder dislocates. So if you leave it this way, it's like a flattened cup. You know, your shoulder can always keep on coming out. So you need to create the bump in front of the shoulder back again. So whatever that's torn, it's not going to heal. Well, some of them heal, but they heal in a very abnormal position. So you have to bring them up back again. So this is what we do. So we can do this through arthroscopically or rather keyhole procedure as well. So the wound is not so big, really small in fact. And this surgery is done probably around 1 to 2 hours. You could be able to do this, right? So, and the patient recovers very well with this. So my advice is, if at all you've had a shoulder dislocation, okay, first time shoulder dislocation in young patients, we always give them a chance. We don't quickly go and suggest them to do this form of surgery. We let them be. We let them be on rested position, and then after a period of time, we get them to their activity and we see how they're doing. So if they are getting a dislocation over and over again, then this is a definite indication for them to undergo this form of surgery. Okay, this is called Bangkat repair. Okay, so this is how we typically do this. Okay, with ankle sutures, and create the bump back again so that the shoulder sits back in the middle and they're stable. Okay, so this is a common complaint that a young patient comes with a shoulder injury or rather shoulder complaint. Okay. Okay, now another question. This is actually more common question than the previous one. I'm getting old and the shoulder pain came out of trivial injury and has been staying with me since then. What could be the cause and how do I treat this? Now, this is a very common question. A lot of middle age or a bit on the older age patient comes to us with a shoulder pain. They can't remember, most of them, on how the injury happened. Okay, but however, they always tell you that, you know, doctor, whatever position I put my hand is painful. I cannot sleep on the side of the shoulder. I cannot lift my shoulder really high. Okay, there could be many reasons to this, but the most common with examination, the most common being impingement. Okay, impingement syndrome. Okay, some of them, these patients a bit on the older age, when they fall down with outstretched hands, some of them can also tear their muscles, or rather we call them as rotator cuff. But examination and also probably some form of investigation such as MRI could easily diagnose this. Okay, I'm going to show you some videos on what are the common cause of this. So I'm going to take subacromial impingement as one part of it. My practice, when I see these patients, when I examine them, when I think that they've got what I call as a impingement of their shoulder, we tend to give them painkillers around the space where it is impinging. And then we see the patient how they are. If the patient tells you, doctor, you know what, after your injection, I'm feeling way much better. So you know where's the location of the pain, or rather what is the cause of their discomfort. So then, because you know injecting these painkillers are not permanent, they are very much temporary, but these are also diagnosis with. So you know exactly where the pain is coming from. This is definitely important because if you're going to do some form of surgery or surgical intervention to them, you have to make sure that, you know, they improve out of it, right? So now this is how we do a subacromial decompression. Okay, so what they're showing you is a shoulder. Okay, 3D. So you can see a space. You can see this red thing and the blue thing. These are tendons, or rather the muscles that's inside the space. So when you lift up your hand, you tend to get stuck under the spurs, or rather the bony outgrowth that you're seeing there. So why this bony outgrowth happens? Some of them are very prone for this because of the shape of their bone itself. But some of them, you know, as they age, they tend to get spurs everywhere. So this is one of those areas where you get the spurs. So when you have this kind of spurs, when you lift up your hand, your muscle gets impinged to it. Your muscle gets injured with it. So one of the ways to do it is definitely to remove the spurs, because there's no medicine can actually take this bone away, right? So unfortunately, you may end up with some form of surgical intervention to remove the spurs. Okay. So after removing the spurs, we tend to get the patient up and moving, and with their physiotherapy right away. Okay, so that they recover as fast as possibly can. Under good indication, this operation is highly successful. Okay, these patients get quite happy with it. Okay, next question. Now, just to fasten it up before everybody gets bored with this. Okay, I've heard of prolapse disc so frequently being diagnosed. Okay, I have occasional back pain. Do I have a prolapse disc and should I be worried? No. Almost 80 to 90% of us will some form or some way or some time of another would have had a back pain, right? So not all of these are prolapse discs. Prolapse disc means is another name for it, slip disc, okay, in which bones are stacked together, where in between them there is a gel, right? So this disc gets bulged or gets prolapsed behind and causes a lot of pain. Now, commonly, a lot of this pain, back pain, are very much related to our activity, lifestyle, the way our posture, the work that we do. Not all of them are sleep disc, but a lot of quite, of course, obviously, quite a number of them come with a diagnosis of a sleep disc. Okay, so how do you know you have a sleep disc? So this usually classically comes as a acute pain, okay, pain of sudden onset. You're lifting something heavy, bending over, not a proper way of lifting heavy weight. Then you have a catch. You heard a sound sometimes, some people, and then you have a severe pain at the back. Sometimes some of these patients, the pain radiates down to your leg, right or left leg, okay, you know, and this pain gets worsened with you coughing, sneezing, you know. These are one of those very strong indications that you had a prolapse disc. Now, this prolapse disc, okay, now, doctor, I've got a prolapse disc. So what happens to me? So do I have to go for some injection? Do I have to go? Not really. In my experience, I think probably 80% of these prolapse disc patient, unless they show you a red flag or a sign of a prolapse disc, big disc, or rather cauda equina, we call them. If it's not that, most of these patients recover with conservative management. Conservative management is defined by, first, you change your lifestyle. You see what is the cause. Are you lying down awkwardly watching TV? Is the way you work in your office? How's the chair? How high is your table? Okay. And how are you carrying your weights? Okay. Change your lifestyle. Second, when you have such a problem, physiotherapy is the mainstay. Okay. Physiotherapy is more important than anything else, especially when you have it for the first time. So I would suggest that physiotherapy is one of the most important thing that I would suggest for the patient. See how you're doing. Let your body heal yourself. Okay, see how it is. Change and then see how you are. Smoking increases risk. Heavy weight, being on the heavier side, increases risk. Some of them now coming up with evidence saying that family history. So you've got a you know, family history, siblings or whatever having with you know, significant prolapse disc. Now you also have got some form of chance to develop this easier compared to other people. Okay, again, I'm stressing prolapse disc common, and it's very important that you go through physiotherapy first, heal them, and then come. So that means probably if you take 10 patients, probably 8 going to be well done with physiotherapy alone. Okay, only 2 more going to come with resistant. That means they're still having pain. They don't know what to do. They've gone through physio. They still don't know what to do. Okay, this group of patients, there are a few options available. Okay, I show them in the animation. Okay, first off, commonly done is a spinal injection. Okay, this is also a kind of under local anesthesia injection. So what we are doing, so what you're trying to see is, okay, this is how the nerve comes out from your spine. Okay, so the yellow thing is the nerve. Okay, and this nerve, the reason for your spine to be, you know, when you have a prolapse, the pain comes down to your leg is because of this. This nerve all travels down to your leg. Now, when you have this pain, the red thing, okay, indicating that you've got a pain. So what we do is that we go under image intensifier in the operating theater with you being sedated, okay? And then we go to the area where your nerve is being painful. This can be diagnosed by clinical examination, also evidence with MRI. So you go to this area and you just inject painkillers around there, okay? This will significantly reduce the feeling of your back pain, your muscle spasm, and also the radiation to your leg. Okay, is this permanent? Not really. It's not permanent. It's very much temporary, but it's very much useful in relieving acute pain. Okay. So another one, well, it was quite famous past few years, but now I think probably it's a bit not too famous, but there are of course definitely people are using it. It's called laser. So what happened is, okay, I show you in animation. It's very easy. Now you see this circle where the nerve is being impinged, right? So if you cut through that, you're seeing this. So this is where the disc is being bulging out and pressing against the nerve. So this laser, what they do is that they put in this probe through X-ray in the OT, and they just laser it under high thermal condition. So this is a very hot thermal laser in which it shrinks the disc. Okay, the disc that's bulged out, it shrinks it. Well, this animation looks as too good to be true and looks really pretty. Doesn't always happen that way. A lot of people are a bit worried because the thermal temperature is quite high. Sometimes it can also injure the nerve around you. Well, that's definitely an option. Okay, field option, that's definitely one. Endoscopic decompression. Now patients are moving away from doing major surgeries to spine. Endoscopic decompression is, I think, is getting a lot of favors here. A lot of people are attempting this and doing this. Okay, we do see very good outcome out of this. Okay, under proper indication. Okay, I'm showing you how is this done. So as okay, so leaves the sound in lah. So what they're doing is they're creating a small hole at the back of the spine and putting these instruments inside. They're called dilators and all that. So this is under direct vision. That means there's a camera inside there, fiber optic camera, in which you can see where the disc is. Okay, this is very, I mean, it's very safe because you're watching the nerve. You can actually see the nerve, and the risk of you injuring the nerve is low. And this is the size of the wound. Well, probably it's a bit bigger than that, but this is average size of the wound, and the patients are put under control and what do you call sedation. That means patients are still able to move and all that. So the idea behind this is doing minimally invasive surgery, just going straight to the point where the location is and directly visualizing the disc where it is bulged out and removing it. So the patient recovers well. Generally, and on uncomplicated cases like this, the surgeons allow the patients to move or rather to walk the very next day. Okay. So that's about spine, briefly. Okay, now next question. Okay, doctor, I hear a lot of people talking about PRP injection. Does it really work? Okay, now PRP is platelet-rich plasma. Okay, what it is actually basically what we are doing is we are taking our own blood, we're spinning it, we're taking the good blood, or rather, it's a layman's good blood, rather plasma, which has got a lot of growth factors in it, and we inject it back to the area where there's injury in our cell to help us to heal. These growth factors go and signal, for healing faster. So where can we use this for? We can use this inside the joint. We can use this for muscle tears. Or we can use it for ligament and tendons. Okay. So now, I'm sure people have heard of this. Okay, this is how this is done. Okay. Okay, show you this. So this is how we extract the blood for PRP from the patient. Okay, so we put it in a centrifuge. Okay, there's a spinner. Okay, this is a machine to spin. Okay, what it does is the high rate spinning divides the blood. So if you see the lower one, these are the cells. So they are red in color. Okay, the above, the yellow one, these are the plasma. This is what we want. Okay, these are the platelet-rich plasmas. Okay, this is how we take them out. So depending on the companies, there are many companies that's doing it. So the fine tune of how they do it may differ, but generally this is what it is. So some of them has got activators. So they activate these growth factors inside the platelet-rich plasmas, and then they inject to the target area. Okay, so do you do this multiple times? Do you do this once? What do you expect? I'm young, I'm old. Okay, can this be done for everybody? Well, theoretically, yes, but generally, these PRPs are quite good for younger age group or on the older age group who are very active. Okay, this is good. So if you ask me to compare, let's say knee, you've got an OA, osteoarthritis of the knee. So which one would you give? Would you give HA? Would you give PRP? Well, if somebody asked me this question, probably I would say look at the grade of the osteoarthritis first, okay, and whether the patient is. Some of the patients they develop osteoarthritis at a young age for whatever reason, injury, trauma, whatever. Okay, those patients who are active, probably we can attempt PRP. Patients who are a bit older, okay, not very active, okay, patient who has got a very high grade osteoarthritis, grade 4. Probably attempting a PRP is an overkill. Probably you want to give them a chance at grade 3, grade 4 for pain relief and all. Probably HA injection works better. Okay, but then again, of course, it's case-to-case basis. You gotta discuss with your doctors and see which are the pro and cons to this. But these are definitely one option, and it's a common question asked to me. So what do you know about PRP? Is this PRP available here? PRP generally available everywhere, kind of, but just finding a proper indication to do it. Probably that's a bit tricky. Okay. Now, last question. Okay, doctor, stem cells are known to be the 21st century treatment in orthopedics. Does it really work? Well, of course, I'm sure we hear the stem cell a lot. Now, there are a lot of challenges with the stem cell. Now, our Malaysia itself are doing a lot of multi-centered studies on stem cell. They're doing a lot of studies, especially a lot of other universities, you know, they are investing a lot of things into stem cell because stem cell is considered kind of a magic. What is stem cell? Stem cell is basically what we are doing now here. Commonly, it's a mesenchymal stem cells. These mesenchymal stem cells are derived from mostly cord bloods, where it's pure stem cells. Stem cell means is a ability of a stem. If the cell is can differentiate into anything. So that is the magic about it. So what the intention is, you put the stem cell into area of injury. Wherever the injury is, those particular cell gonna give out signals, okay? Give out signals saying that, okay, I'm injured, please help me. So these stem cells are supposedly to differentiate into that form of cell and heal them. This is what the whole idea of it. Well, whether it's successful or not, well, it's again, there are good outcomes to this. There are not so good outcomes to this, but of course, definitely it's more and more good outcomes are coming with all the studies and all that. Even our locally produced stem cells, I mean, there are a few companies who are doing very well. Okay, again, if you want to know more about the stem cell, probably it's good to get to your doctors, see whether they are fairly indicated for you. Okay, but it's definitely something that's to look for. Okay, to come in. So I've done.
Thank you, doctor. I like all the videos. And then I actually felt the pain when is that a ligament again when it torn? ACL?
Sorry?
I think you
ACL?
show a video, yeah, when it torn, yeah, I felt the pain too. So
yeah, me too. I literally felt the pain because I've had ACL injury done.
you uh-huh.
I had surgery done on my knee.
That's like there's a lot of concern that especially for people who enjoy sports, after they done the surgery, how long it takes for recovery, and can they really, like a practice or do the sports as usual as they were previously?
Well, the ACL surgery is known to be highly successful surgery, actually. But
All right.
the thing with that is that, the important thing with that is, it's not, no matter how well the doctor does the surgery, the physiotherapy that follows the surgery is the one that's the key factor to this. So the doctor can possibly do an average work with the fixation. If the patient goes for a very good physiotherapy, proprioception therapy and everything, and took a good time before return to sports, they do well. If a
Okay.
did a really good job on this patient, and the patient just stays at home, don't without doing any physio, without going for any physiotherapy, the outcome probably might be a bit more guarded. Okay, in
Okay,
general, under good surgery and also physiotherapy, this is fairly very highly successful surgery, I would say.
I see. I mean, like usually what lifespan? Because I think you mentioned patient's expectation is very important.
Correct.
If you let them know, for example, you give like probably 6 weeks to 8 weeks. I mean, what would you advise?
Well, it depends on the associated injury that they have. For sometimes
Mm-hmm.
they have only ACL injury, and we do the ACL. My patients, I let them walk within a week. I let them bend. We have got our own physiotherapy guidelines. We follow our, I mean, we modify here and there. So how much do you bend first week? How much do you bend second week? How do you do your quadriceps strengthening exercises? When do you go for your proprioception exercises? When do you know you're ready to run on
Mm,
a line? When do you know you're ready to run on a cornered line? When do you know you can go back to your activity? So it's very much in general,
mm.
play futsal, you got injured, you got done your ACL. I tell them to get back to your contact sports back again. Probably you have to wait for 10 to 12 months.
To 12 months. So it depends on severity and case to case basis.
Correct. In general, that's what we take, because we don't
Mm,
go prematurely into activity like sports, contact sports especially, and then rupture the ACL back again.
Okay. All right. Thank you, Doctor. I'm just quickly scroll through the comments to see where the question is. Oh, patient say hi to you.
Okay, of course. Hi.
Right. Okay. Hello, doctor. What types of orthopedic conditions and injuries are the most common? I guess, yeah, maybe it's best to know which one is the most common one so we all can prevent.
Orthopedic injuries.
Yeah, which one are the most common ones that you come across?
Now I'm seeing a lot of back pain, maybe because
Oh,
of
back pain.
PO.
Mm-hmm.
So people are sitting at home and looking at some form of exercises. So there are a lot of these weird, or rather, I mean, exercises that make them to have a lot of back pain. So I'm seeing a lot of back pain patients. I don't know whether,
Okay.
yeah. So whatever exercises you do, if you think that you are venturing into a new form of exercises, you have to go very graded
Mm,
level. Even from somebody who's completely inactive and suddenly
yeah.
want to jump and do something that's really a bit more. So this is prone, you are very prone to get injury, this one. So you have to
Okay.
be slow, yeah, stretching. Let's say this week you're doing a bit slower, next week
Mm.
up a bit, up a bit. So probably that is a bit more safer.
Do it progressively, not to be a Superman, because now there are many jago exercise at home because of COVID-19.
I'm
Yeah,
seeing
and
so many questions here.
yeah, I know.
Okay, I
So,
go through this one. Probably
mm.
some of these that I can actually go through, right?
So
Okay.
you can go through that further. That's good then.
Okay, is
Mm.
it true that long-term use of glucosamine can induce diabetes or increase glucose level? Okay, now, glucosamine used to be a supplement that we used to give for the longest time. Okay, recent studies, okay, has showed that glucosamine probably gives only a placebo effect. Placebo effect means you feel good because you're taking it. You're not sure whether it's working or not. You feel like you have taken that, so I assume that my knee going to be less painful. Well,
Mm.
no obvious evidence saying that it works. Okay.
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 All
But
right.
so in my practice, since
Mm.
it's a bit low, I don't
Mm.
really promote that so much to my patients, unless some of my patients who comes to me and tell me that, doctor, you know what, I've taken this glucosamine, I feel really good about my knee, I see some difference. So if I see patients who comes and tells me that,
Mm.
knew their glucosamine. Okay,
Okay.
but it induces diabetes, not proven. There's no evidence of that.
Okay.
The common brand glucosamine, unless there are some other brand glucosamine that I'm not aware of, but it does not really evidence. I don't see an evidence. I don't see a patients coming with increased glucose level with glucosamine.
Okay. All
Okay.
right. Thank you, doctor.
Second question: patient done
Yeah.
TKR. If they have pain after a few years, will TKR be repeated? Okay. So you have to see what is the cause of the pain. So a lot of patients with TKR, their pain comes because of not okay. Now you came with the pain, degenerative pain. Your knee is painful, and the doctor did X-ray and said, okay, you know what? Your pain is because of the wear and tear of your joint. So therefore, because it's a bit on the higher grade, probably it's good for you to do a total knee replacement. You got to understand there are a lot of other pain generators around your knee. So not necessarily after you've done your total knee replacement, you will never experience pain around your knee anymore. Okay, and it's not necessarily if you have another repeat painful knee, not necessarily has to be because of the TKR. So you got to see, there are a lot of patients that I see, they come with a pes serenus bursitis. A lot of them have got a collateral injuries. A lot of them have got a tendinitis. So it's okay, even though you've done a total knee replacement, the examination or diagnosis goes the same way again. We check back where are the pain generators. Okay, if there are defects of a previous surgery or loosening of the implant that we put in, so therefore you're unstable, so you've got pain. So probably if that is those reasons, then probably you are looking at revision surgery. But not every patient that has got a total knee done and come back with pain is because of the surgery, right?
Okay.
Okay. Third one, I have Osgood-Schlatter disease with early OA of both knees. May I know what are my treatment options? Well, Osgood-Schlatter disease is a kind of a disease that you come as you grow. Okay, so now if you've grown big enough, probably you're having a patella tendinitis. Early OA of both knees. So probably what I would suggest to you is probably you look back at your activity. What are the causes of your pain? So this pain can be persistent if you involve in activity that gets you jumping all the time. So like basketball game, badminton game, this can get worsened with that. So probably I would suggest to you that probably treat the pain before you get back to any form of jumping activity, if at all you're doing that. So probably then you can control the pain. Okay. Okay. Fourth question. Okay, my dad's finger couldn't bend down, movement not well. Is the bone problem or nerve giving problem? So he said after sleep at night, tomorrow morning you'll have this problem. Well, I have to know which finger is that. So you got 5, so I have to know whether it's your little and ring finger, because a diagnosis is different with different fingers. Okay, when they sleep at night, I want to know whether it's elbows. He flexes his elbow, he bends his elbow when he's sleeping. And then when he wakes up, he feels like the finger's numb. Or, he cannot bend because it's stiff. Or I want to know whether the finger is triggering. That means you bend your knee, bend your finger, and then you cannot straighten it back. Okay, it's like triggering. So probably knowing that, probably I can answer this. Okay.
Hey, doctor, I want to interrupt. The second one, how do you say it again? This one?
Which one?
You can't flex it, yeah.
Correct, because sometimes patients come and they tell you that they can bend their finger, but they cannot straighten it. So these are trigger finger. Very common presentation, diabetic patients, this very frequently. So this problem could be because the question could be any of those that the person is asking. It very much depends on a further history that I would like to know.
Is this treatable, this one?
Yeah, treatable. Depends on the grade, but very much treatable. Depends on the grade.
Okay.
Okay, mama saya ada diabetes dan hypertension, melakukan operasi hip replacement dan melakukan fizio 3 bulan tetapi tidak boleh jalan. Sering dapat pneumonia dan bronkitis. Kenapa masih belum boleh jalan? Okay, hip replacement because of fractures ataupun hip replacement disebabkan oleh sendi yang rosak, perlukan fizio yang berlainan. Okay, apa-apa pun, whenever you do a hip replacement, the goal is always to get the patient up and walking as soon as you possibly can, especially if the patient is on the older age. Okay, the longer you keep them bedridden post-surgery, the higher likelihood that they're going to be that way. So in my hands, my opinion would be the moment you've done with the surgery, you are getting them up and moving. Okay, so probably if they're lying down, then you're looking at pneumonia and everything else as a complication. Okay, so physio kerap lagi mungkin. Okay, some more.
Yeah, there's plenty, few more.
Yeah. Okay, a few more. That's it.
Yeah, few more.
Yeah. I had sleep disc 7 years ago at L5, S1, and S2. Recently, the back pain keep coming back, and I feel so uncomfortable. I went to see a chiropractor, but the pain is still there. I even go to traditional Chinese medicine, but the pain is still there. I'm really worried and advice. So probably checking you, getting you checked again, see what is the diagnosis first, and then getting imaging and check back what is the reason of your recurrent pain. The reason of recurrent pain can be a few things. Whether you're still doing the thing that causing you to have pain, that means you're not settling your modification of the possible cause of the pain. Second, probably probably the treatment is not complete yet for you, or probably the diagnosis is different. Okay, we have to check back again, get back to front history, physical examination, and check back the diagnosis. See whether we are going through the proper route. Okay. Yes.
Okay, right. Hope I answer Miss Chiu. Yep. That's a short one. Is walking good for arthritis?
Okay. So walking, for arthritis, low impact walking is good. So if you're walking on a hard, uneven ground, it's not good. If you're walking on a low impact ground, that means let's say you're walking on a tar road, flat road, nothing's happening. With a proper shoe, probably it's okay. If you're not 5-10 kilometers, okay? If you're walking on a treadmill, well, there are two types of treadmill now. There are treadmill with cushions, So the cushion treadmills are good for osteoarthritis patients. Other than that, if you want to walk inside the water, let's just say you find a swimming pool, you go inside the swimming pool and just walk. This is really, really good for your knee. Why? Because obviously some of your weight is taken by the water and you get really tired walking. So rather than spending 1 hour doing 5 kilometers of walking, doing a few laps walking in the swimming pool will settle you down.
Okay, all right. Thank you, doctor. Right. I think that's one that we skipped. Do you mind if I just quickly go back? Just done my genicular block to both knees, but the pain is worsening.
Sorry. Could you repeat? Sorry.
Yeah. Sorry.
Okay.
Okay. Doctor, no more with you. Now I'm with hospital. Blah blah. Just done my genicular block to both knee. I'm guessing that's yeah.
Okay.
But the pain becomes worse.
After the block.
After the block, the pain is worse.
Okay.
Doctor suggests me to do epidural injection for my slip disc. Is there a pro or cons for the injection?
Okay. It very much depends on what your doctor thinks what you're having. Okay. Epidural injection. Okay. All these form of injections are basically what they're trying to do is they're trying to mask what you have. So they're trying to reduce the pain. They're trying to reduce the inflammation that's happening and all that. Well, to say pro and cons, there are a lot of pro and cons to this. So very much depends on how bad you're suffering and how much you have exhausted conservative treatment. Okay, so if you have not done physio at all, okay, or you're not compliant, or rather because of your work being busy and all that, you have not done much, and then suddenly now, if you want to go for epidural, I would suggest no, because you go and do your physio properly first. Get a physio done. See how much he has improved you before you decide on any form of intervention, even if it is injection. So in my practice, I rarely give unless patient has failed conservative treatment. So pro and cons, there are all pro and cons to this. So the doctor, your doctor would have explained to you, would have discussed with you about the pro and cons. So I don't want to contradict anybody, but having said that, but my suggestion to you is you have to look back whether you've done enough conservative treatment before going for this. Okay? Can?
All right, thank you, doctor. So it's 9:27. So maybe, doctor, you pick the last questions.
Last question, huh?
Yeah, you pick the last questions. Can you see the comments, or do you want me to pick?
Okay, that's another interesting question here.
Yeah.
Doctor, if a knee pain goes off after a few days but reappears each time after acts such as squatting or certain particular movement, does it warrant further investigation? Well, to answer this, it very much depends on how bad was the fall. Okay, if the fall was heavy and the pain keeps on coming back to you, probably you definitely need further investigation. Okay, if the fall is very trivial one and you're on the younger side, okay, you have to look back at what is the cause of recurrent pain post-fall. You have to see whether the recurrent pain is really because of the fall or because of some other thing. Okay, but if you had a fall, it's a blanket question. I had a fall, doctor, and I've got a knee pain that is recurrent and it's not going away. You definitely need a warrant further investigation for sure. Okay.
I hope it answered you, Kavita. All right, so I guess it's 9:28 now, and our session has finished. Thank you,
Okay.
Dr. Iswaran, for
Right. Thank
spending
you.
1 hour with us.
1 hour, yeah.
And
Oh my God.
oh, 1 hour, I know. And I think the response is really good. So maybe you
Okay.
need to start another one
Yeah.
when I invite you to do one more session again, maybe on something else.
Okay. Continuously inspire us, you know. You guys inspire us. Okay. Okay.
Okay. All right, I guess let's say goodbye to our audience together.
All right. Bye bye.
Bye.